Welcome to this month's seminar. My name is Sarah Demetrio. I'm with Suburban Hospital's Community Health and Wellness Department. And once a month, we put on these free monthly seminars, talk about an important health topic. And this month, we will be discussing atrial fibrillation. And today, our speaker is Dr. Edward Healy. He is the Chief of Cardiology here at Suburban Hospital and a cardiac electrophysiologist. And he's here to talk to you about atrial fibrillation, what it is, how it's treated, and maybe how it's prevented if possible. So just a few housekeeping items. We will have a Q&A at the end of the seminar, and you can type your questions in the Q&A box at the very bottom. But if you need to shoot me a message in between, you can use the chat option as well. And then following the talk, I will be sending out the recording. This session will be recorded, as well as an evaluation. We'd love to hear what you thought and what you learned. And we look on WellWorks for next month. We'll be doing this again for Thursday of the month at 1 p.m. So without further ado, I will pass it on to Dr. Edward Healy. Thank you, Dr. Healy.
Great, thanks, Sarah. So today we're going to be talking about one of my favorite topics, atrial fibrillation. As a cardiologist and a cardiac electrophysiologist, this is something that I spend a lot of time thinking about and talking to patients about. So I'm glad to get a chance to share this with you. So I'm going to start off with who I am and what am I doing. So I'm a cardiac electrophysiologist. I work with Johns Hopkins Community Physicians, and I have offices in Bethesda and Rockville. I'm the Chief of Cardiology and the Director of Electrophysiology at Suburban Hospital in Bethesda. I'm also on staff at the other Hopkins hospital in the area, Sibley Memorial Hospital. I'll be discussing atrial fibrillation today. I will not be talking about any individual's medical care. So sometimes people have questions about how they were diagnosed with something or what medications they're taking. And this is really not the sort of forum to do that in. But I will be talking about different treatments of atrial fibrillation. I'm going to make a little public service announcement here. I'd like to encourage everybody to get a COVID-19 vaccine. Hopefully all of you already have. And even once you have it, continue to take reasonable precautions. Although it's not exactly relevant to today's talk, it is a major health issue confronting us right now. And I personally have been vaccinated, and I continue to wear a mask and a shield when I'm at work. And I hope that all of you will be sure to get vaccinated. I'd like to start off when talking about atrial fibrillation by looking at the heart, right? So this is a picture of the human heart, and the human heart has 4 chambers, 2 on the left and 2 on the right, 2 upper and 2 lower chambers. The upper chambers are called the atrium, so the right atrium and the left atrium, and the lower chambers are called the ventricles, the right ventricle and the left ventricle. The right heart gets blood that has been used from the body and then pumps it to the lungs, and the left heart gets blood that has been oxygenated in the lungs and then pumps that out to the body. So these two systems work in parallel to each other. And that's going to play a little bit of a role in the things that we talk about with atrial fibrillation. And then I'd like to go over some useful medical terms. So as we just said, the atria are the upper chambers of the heart. There's one on the left and one on the right. The ventricles are the lower chambers of the heart, left and right, and the ventricles are the main pumping chambers of the heart. The heart rate is the number of times the heart beats per minute. So the heart rate is given in BPM, beats per minute, and the normal heart rate is often said to be between 60 and 100 when we're at rest. I think a better way to look at that is that the normal heart rate is probably really more 50 to 90, because people whose heart rate is 50 are more likely to be healthy than people whose resting heart rate is 100. The heart rhythm is different than the heart rate. The rhythm is the electrical sequence of heart activation. And so if we go back and look at the heart for a second, our heartbeats should originate in the right atrium, the right upper chamber of the heart. The electricity should spread out through the left and right atrium and then go down into the ventricles. So those are two terms that get confused a lot, rate and rhythm. The rate is a number. The rhythm is a description of how the electricity is moving through the heart. And then there's the pulse. So the pulse and the heart rate are closely related, but are also a little bit different. The pulse is what we feel peripherally. So sometimes in the wrist or in the neck, and it's the rhythmic throbbing of the arteries that's produced by the left ventricle. So when the left ventricle beats, it pushes out and creates this pulse that travels throughout the body. It is possible for the heart rate and the pulse to be different. Bradycardia is a slow heart rate, and by standard definition, that means any heart rate less than 60 beats per minute. Although, as I said earlier, I really think that 50 is a better lower rate. And tachycardia is a fast heart rate. So any heart rate greater than 100 is a tachycardia. Sinus rhythm is the normal rhythm of the heart when our heart beats are originating in the right atrium, the right upper chamber of the heart. And then arrhythmia or dysrhythmia is an abnormal heart rhythm. So sometimes people say that anything other than sinus rhythm is an arrhythmia or a dysrhythmia. It's a little bit more complicated than that. Sinus bradycardia, so slow heart rates coming from the right place, can be normal. In certain settings, sinus tachycardia or fast heart rates coming from the right place can be normal. What about atrial fibrillation? What is it? Well, atrial fibrillation is an abnormal heart rhythm, so it's an arrhythmia or a dysrhythmia. It comes from the upper chambers of the heart, the atria, and that's where the term atrial comes from. And it usually, although not necessarily, produces an irregular heartbeat or pulse, and that's the fibrillation. So atrial fibrillation is an irregular heartbeat or pulse coming from the upper chamber of the heart, atrial fibrillation. What are the characteristics of atrial fibrillation? Well, classically, it's described as producing an irregular pulse. What that means is that if you feel someone's pulse when they're in atrial fibrillation, there is no pattern to the beats. They seem to be occurring randomly. Additionally, it often, although not necessarily, produces a fast pulse. So most of the time when we examine someone who's in atrial fibrillation, we're going to find that their pulse is rapid and irregular. Oftentimes, patients will describe something like a flip-flop in their heart, as if their heart is beating erratically. That's a very common description. It is more common over about age 65. So atrial fibrillation is extremely uncommon in children. It is uncommon in younger adults. By the time people are in their 80s, it is quite common. And atrial fibrillation can be associated with periods of physiological stress. So things like surgery, sepsis, or breathing problems can trigger episodes of atrial fibrillation. And atrial fibrillation can produce symptoms like shortness of breath and dizziness. Why do we care about atrial fibrillation? It's the most common abnormal heart rhythm. So as a cardiologist, I see lots of patients who have this. Additionally, as our population has gotten older, atrial fibrillation has become more common. It can produce symptoms, as we discussed, sometimes dizziness, lightheadedness, exercise intolerance. It is a leading cause of stroke, and it can lead to weakened heart muscle and heart failure. So clearly, this is something that we need to pay attention to because it is quite common, it produces symptoms, and it can have significant sequelae. These are some common questions that I get about atrial fibrillation, and I'm smiling when I look at this because just before I had this meeting, I was seeing a patient who had recently been diagnosed with atrial fibrillation, and now that I look at this, these are a lot of questions that she was asking. So is it fatal? And the answer to that is really no. Atrial fibrillation is not a fatal condition. Is it serious? Well, yes, it is serious because it can lead to, especially to the risk of stroke, but can also limit people in other ways. Once I have it, will I always have it? That's a great question. And the answer is probably to some degree. I think it's good to think of atrial fibrillation like some other conditions such as hypertension, high blood pressure, or diabetes. Once someone has the diagnosis, they almost always carry it with them. In the case of atrial fibrillation, they may not always be in atrial fibrillation. Their rhythm may come and go between normal rhythm and atrial fibrillation, but it is still a diagnosis that always travels with them. Can it be treated? Yes, and we're going to be talking about that in some of the later slides. Can it be cured? That's one that I'll deal with in some more detail a little bit later. And is it hereditary? And the answer to that is almost always no. There are some rare situations in which atrial fibrillation is a genetic or hereditary condition, but most of the time you can think of atrial fibrillation as really being something that develops over the course of our life, often because of risk factors. Some of those risk factors are modifiable. Some of them, like increasing age, are not. So how do we treat atrial fibrillation? And I'm going to look at 4 different aspects of this. One, because I think it's the most important, is going to be stroke risk. So we always want to look at someone's risk of stroke with atrial fibrillation and make sure they're getting proper therapy for that. Secondly is the heart rate. Is their heart rate too fast? Is it too slow? Do we need to do something to get it in the right range? Heart rhythm. So in atrial fibrillation, do we need to try and get the person back into normal rhythm? Are they going back into normal rhythm on their own? Or are they someone who we can leave in atrial fibrillation without having to restore normal rhythm? And we always want to look for triggers or causes of atrial fibrillation. Oftentimes we don't find these, but we do want to look for them. So we're going to start by looking at stroke risk. And we have this scale that we come up with, which enables us to assess someone who has atrial fibrillation's stroke risk. And the things that we look at are, do they have a history of heart failure? Do they have a history of high blood pressure or hypertension? What is their age? The risk of stroke is lowest under age 65 and is highest over age 75. Do they have diabetes, which increases their risk of stroke? Have they ever had a stroke or a transient ischemic attack before? People who have a history of a prior stroke or TIA are at increased risk. Do they have any vascular disease, carotid disease, coronary artery disease, aortic disease, or peripheral vascular disease, which can also increase the risk of stroke? And then we know that women are at higher risk of stroke than men. So stroke risk reduction. Does everyone need to do something to reduce their risk of stroke? Not necessarily, but everybody should have their stroke risk assessed. Based on those factors that we looked at earlier, we give someone a stroke risk score. If they have none of the risk factors, then their score is 0. And in that case, we generally don't do anything to reduce their risk of stroke because their stroke risk is quite low. And the things that we can do to reduce the risk of stroke can increase someone's risk of bleeding. So if someone has a very low stroke risk, we won't necessarily do anything specifically to decrease it because the things that we do would increase their risk of bleeding. Is aspirin effective? This is a very controversial topic. In the United States, we often recommend aspirin for people who are at low risk and who we don't want to start an anticoagulation, which I'll talk about in a minute. But in Europe, they don't recommend the use of aspirin. I think aspirin can be helpful in people who are at quite low risk, but it's generally not something that we use to reduce the risk of stroke in atrial fibrillation. And that's a change from things that we were doing 5 to 10 years ago when we used to use aspirin more. Aspirin and other medications like it, which are things like, for instance, Plavix, those are other medications that, like aspirin, work against the platelets, are very different from anticoagulant or anticoagulation medications. Sometimes people group these together and refer to them as blood thinners. It's a term that I always try and avoid because number one, it confuses the difference between antiplatelet agents and anticoagulation. And number two, I think it gives people a false sense of what the medications do. They don't make the blood any thinner or more viscous. What anticoagulants really do is make the blood less able to form clots. And I think that's a very good way to look at it. Anticoagulation reduces the risk of stroke by making it harder for the blood to form clots, which is great. However, it will also, of course, increase the risk of bleeding since clots are how we stop bleeding. Does everyone who has atrial fibrillation need anticoagulation? The answer to that is no. We should look at each patient's stroke risk, look at their bleeding risk, and also consider how much atrial fibrillation they're having. And that's really how we decide who needs anticoagulation and who doesn't. So this is something that should really be tailored to the individual. And a question that I get a lot is anticoagulation safe? I think the answer to that is yes. Like all therapies, it definitely carries some risks associated with it. In this case, specifically an increased risk of bleeding. However, one of the anticoagulation medications that is quite commonly used, and that's apixaban, which goes by the name Eliquis, was actually given a head-to-head trial against aspirin. Not surprisingly, Eliquis was much better than aspirin in reducing the risk of stroke and really had the same bleeding risk as aspirin. So I think that anticoagulation medications are quite safe when used appropriately. I do want to take a minute to talk about another option to reduce the risk of stroke besides anticoagulation, and that's a left atrial appendage closure. So this is something that we use in patients who, for some reason, can't take anticoagulation. Perhaps they've had significant bleeding while they're on it. Perhaps there's someone who has a personal history of having had a bleed inside their brain, or they've had recurrent gastrointestinal bleeding. What we do in this procedure is the left atrial appendage is a small piece of the left atrium that sort of hangs off of it. And we know that that is generally where the strokes come from in atrial fibrillation. And this little device is advanced through a vein and across the heart from the right atrium to the left atrium, and then placed in the left atrial appendage closure, and in the left atrial appendage, closing it. And we know from studies that left atrial appendage closure is as good as anticoagulation in reducing the risk of stroke and has similar risk profile to it. So this is another option that we can use sometimes to reduce the risk of stroke for patients. So the next thing that we're going to talk about is heart rate. We've already addressed what the normal heart rate is. It's either 60 to 100 or 50 to 90, depending on how you look at it. But that's not necessarily what we're looking at in atrial fibrillation. Most of the time, the target that we set is to reduce someone's heart rate to less than 100 beats per minute. There have been some studies that have looked at tighter control versus looser control, and we haven't necessarily found a significant difference. We do know that if you allow patients' heart rate to remain elevated in atrial fibrillation, if they're going around with a heart rate of say 120 to 130 or even 140, that can weaken the heart over time. So most of the time we're setting a target heart rate at rest of less than 100 and usually less than 90. Another question that I often get is, do I need a pacemaker? So the vast majority of patients who have atrial fibrillation do not need a pacemaker. We do sometimes use a pacemaker because some patients paradoxically don't have fast heart rates when they're in atrial fibrillation, but have slow ones, and they may need a pacemaker. And additionally, sometimes a pacemaker can be used to help control the heart rate in atrial fibrillation. If somebody has very slow heart rates on medication and fast heart rates off it, sometimes we'll use a pacemaker to support the lower rates and make their treatment easier. Next, we're going to talk about heart rhythm. So Atrial fibrillation is sometimes said, and it's not really correct, but sometimes said to come in three varieties. Paroxysmal, so that means that somebody comes in and out of atrial fibrillation. Persistent, meaning the person goes into atrial fibrillation and will stay in it unless we do something to get them out of it. And permanent. In permanent atrial fibrillation, we believe that this is what the person's rhythm will always be going forward. We sometimes think that people sort of move from one category to another, but that's not really true. Everybody's atrial fibrillation is different, and although these are terms that we use to describe it, they're not really a gradient. In other words, permanent atrial fibrillation is not necessarily something that's worse than paroxysmal atrial fibrillation. It's more of a descriptive set of terms that we use. This is definitely not the same thing as rate control. Rate control, remember, is referring to how fast the heart rate is going. When we're trying to control the rhythm, we're trying to get the person back into normal rhythm and keep them in normal rhythm. And there are a few different things that we can do about that. We can use medications, and there are a lot of medications that can be used to try and keep somebody in normal rhythm. These are medications that can have a lot of different side effects or toxicities, and they should be used carefully. We can do cardioversions where we try and shock someone's heart out of atrial fibrillation. When we do a cardioversion, the patient's heart actually stops for a second, and then it usually starts back up in normal rhythm. Many times after we do this, we'll use a medication to try and keep the person in normal rhythm afterwards. And then ablation. So ablation is a common therapy now that we use for atrial fibrillation. And if we go back to our picture of the heart, in the late 1990s, some cardiologists in Bordeaux, France, and I don't think that that's a coincidence. We do know that there is an association between alcohol intake and atrial fibrillation, and Bordeaux is, of course, a place famous for its wine. So in Bordeaux, France, in the late 1990s, some cardiologists figured out that atrial fibrillation is not only coming from the atria, the upper chambers, but is almost always coming from the left atria. And it's actually almost always coming from where the pulmonary veins, and these are the veins that are returning oxygenated blood from the lungs to the heart, meet the left atrium. And they decided to try and electrically isolate those veins to prevent atrial fibrillation. And this has turned out to be a very effective strategy over time. There are a lot of different ways that we do this. Sometimes we use heat energy, which is called radio frequency ablation. Sometimes we use cooling, which is called cryoablation. Sometimes we do it surgically. The key is you want to maintain blood flow from the veins into the atrium, but not allow electricity to move between the two. Atrial fibrillation ablation can be a very successful strategy in properly chosen patients. It is common for patients to have more than one ablation to successfully get rid of their atrial fibrillation. And this has been around for about 20 years. So we have good data on sort of 5 and 10-year outcomes, but we don't really have data on timeframes longer than that. So another thing that we're going to want to look at in a patient with atrial fibrillation is, are there triggers or causes that we can identify? I just mentioned about alcohol. Alcohol is a common trigger for atrial fibrillation. The British have a term for it. They call it holiday heart. So somebody goes on holiday or vacation, drinks more alcohol than they normally do, and develops atrial fibrillation. We do know that in certain patients, it actually doesn't depend that much on the amount of alcohol that they take in. I have some patients who know if they have one glass of wine or a beer, they're likely to go into atrial fibrillation. And there are other patients who don't find that alcohol has any impact, but that is something to look at in each individual patient. Caffeine is somewhat controversial, whether or not caffeine can trigger atrial fibrillation. Certainly, very large intakes of caffeine can, but in most people, having 1 to 2 cups of coffee a day, for instance, is not going to trigger atrial fibrillation. An overactive thyroid is something that we always look for, and that can trigger atrial fibrillation. Sleep apnea is an important risk factor for atrial fibrillation. We know that patients who have sleep apnea are much more likely to have atrial fibrillation than patients who don't have sleep apnea. And we also know that if we treat sleep apnea, we can reduce those people's risk of atrial fibrillation. And playing in very much to sleep apnea is obesity. Obesity is the #1 risk factor for sleep apnea. It's also one of the highest risk factors for atrial fibrillation. In fact, in Australia, a group there did a study of taking patients who had obesity and atrial fibrillation, and they compared 2 different strategies. One strategy was using medications and ablations to try and get them back in normal rhythm. The other strategy was an intensive program of weight loss, and they found that these strategies were essentially equivalent in their outcomes. And then another thing that we think about is lung problems. Besides sleep apnea, other lung problems such as COPD or emphysema can act as a trigger for atrial fibrillation. Can atrial fibrillation be cured? Our answer to that has always been no. Atrial fibrillation was not something that we considered to be curable. That has changed a little bit over the last decade or so, and perhaps the people who are strongest advocates for an ablation strategy would say yes. They would say, you know, I have plenty of patients who have had AF ablations and have been cured of it. I think the answer is probably somewhere in the middle. I think there are definitely patients, and I have patients who have been cured of atrial fibrillation, at least for some period of time, 5 years, 7 years. But that is not the story for the majority of patients. Perhaps as we get better at ablation, that might change. But right now, I think that is the exception rather than the rule. Another thing that I'd like to comment on is looking for atrial fibrillation. And there are a lot of different devices out there that can do that now. Some of them are very simple, like a pulse oximeter. A lot of people have become familiar with this during the pandemic. It's a way Yes.
Dr. Healy, I'm so sorry. It looks like the slide is still on the rhythm slide.
Oh. Okay.
Sorry. Oh, there we go.
Okay. Got it. Thank you.
Thank you.
Okay. So pulse oximeters are something that people have become familiar with during the pandemic. It measures the oxygen saturation of blood and also gives a heart rate. So if someone has atrial fibrillation with faster heart rates, they can see that on the pulse oximeter. There are a number of smartphone apps available to track atrial fibrillation. I myself have a smart watch that is capable of tracking atrial fibrillation. And then more medically, we have implanted monitors that we sometimes use, and pacemakers and defibrillators can also track atrial fibrillation for us. So there are a lot of different ways to diagnose atrial fibrillation currently, and some of them patients can use on their own to track atrial fibrillation. So another common question that I get is, what can I do? So if a patient is found to have atrial fibrillation, or perhaps in a broader sense, what can I do if I want to avoid getting atrial fibrillation? Well, I think that the single biggest thing that I would recommend, because it has so many other good health benefits, is maintaining a good body weight. Having a good body weight decreases the risk of atrial fibrillation, hypertension, sleep apnea, and so that would be very high on the list. And tied into that is regular exercise. Regular exercise has been shown to decrease the risk of atrial fibrillation. Number 3 is controlling hypertension. So for people who have high blood pressure, making sure that their blood pressure, either through medication or a combination of diet and exercise, is well controlled, can help reduce their risk. Treating sleep apnea. And I'm oftentimes recommending that patients get sleep studies, and if they are found to have sleep apnea, getting appropriate therapy for it. And then modifying alcohol intake. These are all things that people can do to reduce their risk of atrial fibrillation, or if they have it, to reduce the amount of atrial fibrillation that they have. And those are my slides for the presentation, so I'll be happy to take any questions.
Thank you, Dr. Healy. That was great and very informative. And if you have any questions, please feel free to type it in the Q&A box and we will get to them. Okay, so our very first question is, what is junctional rhythm?
What is a junctional rhythm? Great. So let me see if I can get my slide back up there. Can you see my slides right now?
I see at Johns Hopkins University in medicine.
So I may not be able to get them back on that screen right now, but basically a junctional rhythm is a rhythm that originates where the upper chamber, the atria, meet the lower chamber, the ventricle. There's a part of the heart that lives there that's called the AV node because it electrically connects the atrium and the ventricle. Heartbeats that originate there are called junctional. So they're different from, say, sinus rhythm or atrial fibrillation in that the heartbeat is not originating specifically in the upper chamber, but they're also not ventricular arrhythmias originating in the lower chamber. They're originating at the junction between the upper and lower chambers.
Oh, thank you.
Is there any relationship between atrial fibrillation and dementia? There are studies that have shown that atrial fibrillation is a risk factor for dementia. That may possibly be due to microemboli or small strokes affecting the brain. So there is a relationship there. And that's one of the reasons that we are so interested in pursuing and treating atrial fibrillation. Another question, is 325 milligram daily aspirin better or worse than a drug like Eliquis for atrial fibrillation? Well, aspirin was tried head-to-head against Eliquis in a study, and Eliquis, which is apixaban, was found to be more protective, significantly more protective against stroke than aspirin, and had the same bleeding risk. So if that question comes up for a patient, I would almost always recommend the use of an anticoagulant like apixaban or Eliquis, who's going to provide better protection against stroke with the same bleeding risk. Can my family doctor diagnose if I have atrial fibrillation? Yes, it's commonly picked up by primary care physicians, mainly because they are the healthcare providers who see the patients most often. If a person has intermittent atrial fibrillation, at what point should there be enough concern to go to the hospital? That's a very complicated question. I think that a way that I would answer this is, number one, it depends on the clinical scenario, but I think that if somebody is having significant dizziness, lightheadedness, feeling like they might pass out, if that rapid heart rate is associated with chest pain or shortness of breath, then that's the time to go to the emergency room. In other words, I think it really depends on the severity of the symptoms. Is it okay to stay on Tambicor over months or years? Tambicor is it's an antiarrhythmic, one of those medications we talked about that is used to keep people in normal rhythm. And the answer to that is usually yes. Tambicor does not carry long-term toxicities to the liver, the lungs, the thyroid, like some of the other medications do. There may be some conditions where Tambicor or flecainide, as it's also known, should be stopped. So it shouldn't be used in people who have a history of coronary artery disease or prior heart attack. It shouldn't be used in patients who have heart failure. And it should be used cautiously in people who have some other conduction system conditions. But it is generally a medication that can be used for a long period of time successfully. What about a PFO, a patent foramen ovale? That's a small hole between the left and right atrium, or mitral valve prolapse risk factor. I guess the question is, are those risk factors for atrial fibrillation? I usually don't think of a patent foramen ovale or a PFO to be a risk factor for atrial fibrillation. In terms of mitral valve prolapse, anything that causes backflow from the left ventricle to the left atrium, so things that affect the mitral valve, so anything that causes mitral regurgitation or that backflow, can increase the risk of atrial fibrillation. So mitral valve prolapse, which can cause that backflow, can be associated with atrial fibrillation. What is termed for an extra heartbeat? Extra heartbeats are often referred to as either PACs for premature atrial contractions or PVCs for premature ventricular contractions. And that depends on whether the beat is coming from the upper chamber or the lower chamber. Those are almost always not dangerous. There are some rare exceptions, but they are almost always not dangerous. Is Xarelto the same as Eliquis? No. They are both anticoagulant medications. So they're both medications that we use to reduce the risk of stroke in atrial fibrillation. But they're two different medications. They're related, but they are different medications. So this question was, when atrial fibrillation is diagnosed at age 18 for a young man who is athletic and normal weight with high blood pressure, no significant apnea, would this be a good case for considering genetic causes? Are there race-related factors about atrial fibrillation? The young man in question is African American. I don't think that we have enough studies on the genetics to say if there are specific race-related factors. But that is definitely someone who you'd want to consider possible genetic causes. So in a patient like that, you'd want to look at first-degree relatives, parents, siblings, go back another generation, or look at grandparents and see if there's any history of atrial fibrillation at a young age. I will mention that although exercise is good for atrial fibrillation, people who are quite athletic may actually have a higher risk of it. So we know that there's a higher risk, for instance, in marathon runners. So there's a lot of things in play there, but that is someone that you would consider that in. I see then there's a group of questions about how Xarelto and Eliquis are different. So I think the easiest way to answer that is that Eliquis is a twice-a-day medication and Xarelto is a once-a-day medication. There has never been a head-to-head study comparing Xarelto to Eliquis for stroke risk reduction. I don't think we're ever going to see that study because the companies that make it wouldn't want that to happen, because you don't know the answer and one of them would be the loser in that competition. Or they could be equivalent. I like to think of them as essentially being equivalent. I think which one I use depends on patient choice primarily. There are some specific situations where one might be favored. So in people who have advanced renal disease, you would favor Eliquis over Xarelto. But in general, they're quite equivalent. What is the relationship between left bundle branch block, which is a type of conduction system disease where there is slowed conduction from the AV node to the left ventricle, and atrial fibrillation? Does it raise added concern? I don't think there's really an exact connection between a left bundle branch block and atrial fibrillation. Certainly, you need to consider left bundle branch block when you're treating atrial fibrillation, because some of the medications that are used to treat it, someone, for instance, earlier brought up flecainide or Tambacor. So there are some medications like that you might not want to use in somebody who has a left bundle branch block, because it may affect the conduction system in a way that might not be good in someone who has a left bundle branch block. So I don't think that there's exactly a relationship there. Added concern, I think it might change the therapy that you use. I think that's a better way to put it.
Okay, well, that covers all our questions for now. Any last minute questions from our audience? Oh, one more, two more. Are you aware of current clinical research studies of the relation between AFib and dementia in this geographic area?
I am not aware. I'm not. Right.
Okay.
Well, that's the next one is what exercise regimen would you recommend for a new onset AFib in a 70-year-old woman? That is perhaps a little bit specific, but that's something that patient should talk to their doctor about. Is low diastolic pressure connected to atrial fibrillation? Not necessarily.
Okay, well, I think that concludes our presentation today on AFib. Dr. Healy, thank you so much for your time and expertise on this subject matter. We really appreciate it. It was a great webinar. And again, this is recorded and will be sent out shortly, as well as the evaluation. So stay tuned for that.
Well, thanks for having me. I enjoy doing it.
Great. Well, we'd love to have you back soon. With that said, thank you everyone for joining us this afternoon, and we hope to see you back again next month. Have a great day.